Good afternoon. My talk, it was put down as the pain scientist. That's exactly what I am. But what I've tried to do the entire time I've worked in pain is to translate from the preclinical science, from mechanisms of pain transmission, mechanisms of modulation, and also mechanisms of how treatments work, and to apply that to the patient, but also to consider the other aspect. When there are problems with the clinical control of pain, how can we back translate from the clinical to the basic and fix things? So upstairs it says it is praiseworthy to alleviate pain, and that is exactly correct. But as the space era was starting, Pat Wall and Ron Melzack had put forward a theory of pain, the gate control, which I'm sure you've all heard of. But basically it said that there was a battle between touch and pain, that entered the spinal cord through afferent fibers. There was modulation in the spinal cord, and this all led to the use of TENS and neuromodulation, and eventually to spinal application of analgesic drugs. But also they suggested that the brain could control the spinal cord to some extent, and that led us to think about pain not simply as a sensory event, but also as a psychological and emotional event as well. So this is kind of where we are now. We know that the majority of pains arise from peripheral events, that nerves can become damaged, neuropathic pains, tissue can become damaged by surgery, by trauma, by disease. And those impulses run within the peripheral fibers into the spinal cord and generate changes already at this first relay. So before anything gets anywhere near the brain, the spinal cord has a remarkable capacity to alter those messages. And then those messages run to the brain, and we all know about the cortex, the map of the body, the homunculus. That's how we know where our pain is, how we locate it, and how we can describe its intensity. But left out till very recently, and I think the last 25 years has seen a change here, we have the limbic brain, our ancient brain, looking out at the world around us, looking at our body, responding and generating our personal sense of ourselves. And pain disrupts that, generating the fear, the anxiety, the sleep disorders that are so common in patients with pain. But the brain can talk back to the spinal cord, and we have these red or stop signals, and we knew about those 25 years ago. But it's also very clear there's a go signal from the brain, an enhancing mechanism, which maybe is active when patients are anxious and catastrophizing, which makes pain worse. And so we can see how if you have a psychological intervention, you can alter those higher processes. You could have regional anesthesia, local anesthesia, block the periphery, or you could manipulate central transmission as well. And so we can start to put up a nice picture of these events, starting in the periphery, running through into the spinal cord. And the blue boxes on the other side show risk factors for chronic pain. So with post-surgical pain, with mastectomies, thoracotomies, hernia repair in particular, but knee replacements, hip replacements, if you have a sensitized spinal cord and a failure of some of these descending inhibitory pathways, you are at much higher risk of having a persistent post-surgical pain. And so we can see how these events have an interplay in terms of generating an individual pain experience with acute pain, but how they can lead on to chronic pain as well. So now it's very clear that we should be subdividing pain, and this is a broad general one. The sort of nociceptive pain, tissue damage, chemical activation, surgery trauma, and the disease would be osteoarthritis. And then by contrast, tissue is normal, but nerves are damaged or diseased, neuropathic pain. And the key point here is that tissue damage pain is generated by chemicals, nerve damage is generated by electrical changes within the nerve. And so the whole therapies aimed at the periphery have to be different for these types of pain. But then we have the coexistence, low back pain and cancer pain, very convincingly with issues of damage to tissue, but damage to nerve as well. The dysfunctional pains, the so-called sort of fibromyalgias, Those we can't explain really in terms of peripheral events, but it's more likely to be abnormalities, aberrations in the central modulation and controlling of pain. But very importantly, that if you have high-risk surgery, mastectomies, thoracotomies, hernia repairs, post-surgical pains are inevitably neuropathic. And so at the time of the surgery, the tissue is damaged, but that will heal. Nerves don't heal, and so the persistent post-surgical pains very often have neuropathic components and become persistent. So where are we in terms of seeking the Holy Grail? Well, one way would be to say, well, let's stop pain out in the periphery, but we have this bewildering number of chemical mediators of pain up here. The prostaglandins, obviously, the targets for the non-steroidal anti-inflammatory drugs, the targets for steroids. And that's all fine if we have the nociceptive pain. We can use non-steroidals for that. But if we have a neuropathic pain, there are none of these chemicals active. The nerve itself is damaged, and it's the electrical vents that have gone wrong. And so we have agents like lidocaine, blocking sodium channels, gabapentin, pregabalin, modulating calcium channels. And so there's a real logic now to the use of these agents, but they have to be considered in terms of the type of pain. But this is an oversimplification, and right at the end of my talk, I'll return back to this. But if we have nociceptive pain and we have a large number of these chemicals, is there any way we're going to improve therapy? And I think the answer is yes. So here, if you remember anything about this talk, it'll be because you have neurons wired up, the billions of neurons in your nervous system, and in early life, nerve growth factor allowed that to happen. But this molecule switches off when we're teenagers, we're wired up normally, the brain is fixed, and we get on with life. But if we damage tissue, this mediator is released again, and therapies now designed to block its action have proved to be very successful in osteoarthritis, in cancer pain, and in low back pain. There are side effects of these therapies, but this is a really sort of interesting molecule that came out of the blue and is now translating through to potential for therapy. And we have drugs that are aiming for some of these other events as well, ATP, etc. But pain and pleasure, there's a fine line. And one of the other issues in life is that we have chemicals that are released in damaged tissue, but we have some chemicals that are very important in molecular gastronomy, things we like to eat which activate sensors in our mouth, our tongue, etc. And TRPV1 here is a beautiful example of that. If you have too much chili in your curry, that burning sensation is because capsaicin in the chili has hijacked TRPV1, activated it, and this is the human heat pain sensor. That's why we have that burning sensation. And capsaicin can be a therapy. But we have a whole family of these TRP channels. If you like mint, TRPM8 is the cold sensor, mint activates that. But many patients with neuropathy and chemotherapy-induced neuropathy are hypersensitive to cold. So drugs targeting the cold sensor could be helpful. And then we have another sensor that responds to almost everything on this plate, garlic, cinnamon, horseradish, etc., TRPA1, and that, overactivated by tear gas, for example, is painful as well. So we have a whole number of new targets in the periphery where we may end up with drugs which might rival or emulate the non-steroidals, but we haven't got them yet. So neuropathic pain, this kind of paradox in a sense, because neuropathy by definition is a loss of peripheral nerve input. But we now know that if you have peripheral fibers that have been lesioned or damaged, they can generate ectopic ongoing pain. So patients very often say with diabetic neuropathy, I have no sensation from my foot, but it's painful. So disconnection from the cutaneous tissues, but the remaining stumps of nerves are generating an ongoing pain. And very interestingly, many other patients who have some fibers still connected, they have evoked pains, the allodynias, the hyperalgesias, the sensitivity to brush and touch and cold, and that we best explain by central sensitization. So there's a kind of continual interplay between the pathological events out in the periphery and processing centrally. And the kind of nice thing about nerves is that the analogy is that it's like driving a car. So if we want to get going, we press on the accelerator. Well, sodium channels generate action potentials. We need to brake. That's the potassium channels. They hyperpolarize, they inhibit. And you could drive by braking and accelerating the kind of Italian way. You get there pretty quickly. It's a bit erratic. So we have a transmission system in the car, and calcium channels serve to release transmitter, playing a similar role. So we've had drugs that have been around for a long time, carbamazepine, lidocaine, blocking the sodium channels. And very interestingly now, we know absolutely categorically that patients with neuropathic pain who have ongoing pain, those drugs don't help. If they have evoked hypersensitivity, the drugs work really well. So we're starting to be able to predict responses to therapy based on different pharmacologies. The opioids open potassium channels, they shut down pain signals, and gabapentin and pregabalin, by serendipity, were never designed to work on calcium channels, but that's what they do. And again, the discovery of these agents and their original aim for use in epilepsy has moved on to being first or second line drugs for neuropathic pains, and they modulate calcium channels. And very interestingly, have a quite remarkable pharmacological action, which is they prevent the calcium channel from getting to the right place. So when those drugs bind to the channel can't go into the membrane, it can't release transmitter, and that's how those agents are able to reduce pain. But with all these novel targets, one of the problems is we need the pharmaceutical industry to make drugs. And only when the drug comes along do we have proof of concept that that target was right, the drug reached it, it has an effect in patients. But there are channelopathies, and these are absolutely intriguing. So sodium channels, mice have 9, and so have we. Basically in pain, if you're a mammal, you're going to be the same as every other mammal. And those trip channels, those gastronomy channels and hot and cold channels, came from the fruit fly. So we have a very old evolutionary system in terms of pain mechanisms. So humans have got 9, and one in particular, 1.7, there are 3 channelopathies, which tell us how important peripheral sodium channels are, and in particular this one, for generating pain. So if you're born without it, you have no pain at all, which is a disaster for those children because they have multiple injuries. There's no survival feedback which pain is generating. But you can have perfectly normal tissue, perfectly normal nerves, but abnormalities in the threshold and the activation of these channels, and you have a pain syndrome with no pathology whatsoever. So these could become very interesting targets. Sodium channels dedicated to pain transmission. And here's TRPA1, the thing that responds to garlic, that responds to tear gas. There's a human mutation of this, and again, episodic pains with no tissue damage at all. But this, I think, is really interesting. So the first family were from Colombia in South America. They're an agricultural family, and at the end of the day, they noticed they had this excruciating pain syndrome because they were hungry, they were tired, and they were hot, so they'd jump in a river. And so many patients say, I'm pretty okay during the day, but if I'm hungry or tired, then my pain comes along. And it's quite remarkable how this ion channel in the periphery can have its function modulated by these kind of central homeostatic mechanisms. It's intriguing. So neurons in the brain are waiting for messages, they need chemicals. And one of the huge steps forwards, and a great example of translation, is central hypersensitivity. So spinal cord neurons here in the spinal cord waiting for peripheral input sit there, and a repeated painful input onto these neurons produces wind-up. It's just like you can wind up your friends and colleagues by making the same repeated facetious comment. Well, in terms of these neurons, repeated painful inputs generate wind-up. And that's the neuronal version in Humans, it's temporal summation. So a repeated painful stimulus, your pain goes up. But something happens now, because these hypersensitive neurons, where the pain inputs early in that pain state, so it could be early in surgery, for example, cause hyperexcitability, and now weak inputs that shouldn't activate these cells can, so the receptive field expands, and things like touch and cold that are not normally painful now access these pain signaling messages. And we have drugs that can block this. Ketamine blocks the NMDA receptor, so at sub-anesthetic doses, so very good analgesic. And this is basically what wind-up does to your pain. So red is what the periphery has told the spinal cord, blue is what the spinal cord is telling the brain. And so if there's ever a mismatch between a scan or an MRI or an X-ray, hardly any damage, but your patient is reporting high levels of pain, well, C-fiber inputs from that area could have caused this central hypersensitivity. So as far as their brain is concerned, that's how much pain they've got, a huge amount, even though the peripheral input is small. So a step forward, there's major side effects, because again, if you remember anything about this lecture, the NMDA receptor in your hippocampus needs to be activated in terms of memory and cognition. And so there's attempts to try and manipulate this system in a more acceptable way. So every individual, based on what's coming in from the periphery, what's happened in the spinal cord, triggers activity in the brain, and everybody makes up their pain experience, their hopes, their fears, their anxieties. Has that pain been explained to them? Is it sinister, etc., etc.? And it's all to do with the cortical areas in our limbic brain, where aversion, sleep, mood, anxiety, etc. are all being generated. And we have painful inputs into these areas, and then this remarkable series of interconnections. And one of the very early steps in pain research was to say that within these circuits there were three types of cells. Some cells not bothered with pain in any way at all, some cells that switch pain off, and others that switched it on. And so we have excitatory descending pathways from the brainstem to the spinal cord. We have inhibitory pathways. And we can put a pharmacology on that. So noradrenaline is inhibitory, that alpha-2 adrenoreceptor in the spinal cord, waiting for descending noradrenaline. And that, of course, can be targeted with clonidine, dexmedetomidine. 5-HT is rather mixed. It's inhibitory in headache through the triptans, but in many other conditions, it appears to be excitatory. And this is the rationale for the use of the antidepressant drugs, which are manipulating these monoamines. But these are descending pathways deep in our brainstem, running through to the spinal cord, and yet we can monitor them in humans. And we can image this preclinical anatomy and see absolutely identical areas in the human brain. But this is the old limbic brain. We shouldn't be surprised. But how can we monitor this? Well, this picture is in the Loire Valley. No art historian has ever managed to explain it, but it's two sisters and one is pregnant. So it's conceivable that this one here is going through childbirth and her kindly sister is applying a second painful stimulus. And you might say, why? Because one pain can inhibit another. In animals, it's called diffuse noxious inhibitory controls, whereby painful inputs trigger the descending noradrenaline inhibition. In humans, it's called conditioned pain modulation, and is very often monitored by having heat on the hand versus cold water on the foot. In the healthy population, one pain inhibits another. And this is lost in pathological states, in neuropathy, in migraines, in osteoarthritis, in fibromyalgia. This descending inhibitory pathway fails. So if you go and have surgery and your descending inhibitions are not working well, the risk of persistent pain is considerable. But it's quite amazing because the presence or absence of descending inhibition and these monoamine pathways has been used to predict whether antidepressant drugs work or not in patients with neuropathic pain. And that's where I kind of want to finish off. Because behind here is the complex pathways of pain with the pharmacology put onto them. We can understand the emotional, the sensory components of pain. But here we have a huge number of patients with neuropathic pain. And by doing sensory testing, and this is looking at warm, cold, heat, pressure, etc., there are 3 subgroups of patients. Patients with sensory loss, and they're the ones who don't respond to the ion channel blockers. Some with thermal hyperalgesia, some with mechanical. And so within this group of patients, and it's true for patients with persistent post-surgical pain, it's true in fibromyalgia, there are subgroups. And so the next steps in the next 5 years will be looking at the pharmacology of this. And it's very likely that these subgroups will have differential responses to the drugs that we have. And by monitoring their descending controls or simply their sensory symptoms, which must be reflecting mechanisms, we can maybe target pharmacology in a far more interesting way. So the kind of pain man here from medieval times, I think we now understand perfectly well that there are multiple mechanisms. Those multiple mechanisms can be modulated by different pharmaco and psychological therapies, and that by subtyping patients, their sensory symptoms must be a surrogate of mechanisms. We can then fix that with the correct drug. And that's where I think the future is going to take us. Thank you very much indeed.